This is a video summary of the Psychosocial Assessment project completed by Becca Forsythe and Janelle DeBell as required for our course Chronic Illness and Disability at Rutgers University School of Social Work, State University of New Jersey. We were asked to team up with a partner to create a fictitious interview session where we could take turns portraying a social worker conducting a psychosocial assessment and the client being interviewed. We started early in the semester to plan our approach. Early on, we agreed that we should use a structured assessment tool or set of tools to make sure we capture the assigned information as easily and comfortably as we could. For the basic shell, we found a form titled Adult Psychosocial Assessment that the Family Services Center of Galveston County sends prospective clients. We decided to use this as clinician-conducted instead of self-report so we could have a form to follow, allowing us to focus more on the process and less on the nerves of performing the task. We supplemented this tool with a few self-report tools that are found pretty frequently in other contexts, such as the Patient Health Questionnaire, or PHQ-9, which was originally developed as a quick screening tool for primary care doctors to screen for depression, and the GAD-7, the Generalized Anxiety Disorder Questionnaire that checks symptoms of anxiety. We also used the CAGE-AID screening tool to check for substance abuse concerns. From there, I decided to specialize my approach. My partner and I had agreed ahead of time that I would be a caseworker at a local nutrition clinic who was seeing Lily Perez for the first time on the recommendation of her primary care physician. She had recently been diagnosed with diabetes type 2 and a combination of health factors that caused her doctor enough concern for him to refer her to our clinic for more intensive and focused treatment of conditions related to her nutritional health. In anticipation of working with a client with type 2 diabetes, I researched a variety of tools specific to diabetes. I chose the Diabetic Empowerment Scale short form because it helps me to measure Lily's self-efficacy in relation to her condition. I decided to use this as clinician-conducted because it allows me to interject motivational interviewing techniques and enrich and empower the conversation instead of just having her complete this impersonal form ad nauseum. I also spent some time researching the symptoms and complications that come with diabetes type 2 so that I knew what I should be tuned into. Normally in the clinical world I don't get that luxury, but since we're pretending, I decided to take full advantage. I spent some time on the website for the American Diabetes Association familiarizing myself with the guidelines for normal ranges expected for factors like blood glucose level, AC1, cholesterol, blood pressure, weight, BMI. Once I had enough time researching it all, it was time to go live. Our pretend session starts with Becca the social worker meeting Lily in the lobby of the nutrition clinic and walking her back to my office for an intake interview. I followed the framework of the Adult Psychosocial Assessment and learned a lot of important information about my client, the fictitious Lily Perez. She is 48 years old, living alone in Bergen, New Jersey. She identifies as 100% Cuban and a lapsed Roman Catholic. She and her husband of 20 years recently divorced. Their 2 adult children, aged 23 and 25, don't live in the area, but still provide her with some social support because she gets to talk to them on the phone. Throughout the course of the interview, I was able to determine that Lily only has a high school diploma and is currently laid off from her job as a prep cook at the Outback Steakhouse. Her finances are getting tight and she's worried about losing her apartment. The combination of concerns is causing her to feel depressed and anxious a lot of the time, and it's interfering with her ability to sleep, concentrate, focus, or pay attention to the necessary self-management routines required by her new diagnosis. It's causing a decline in her quality of life that has caused enough concern for her primary care doctor to send her our way. After the 1-hour interview, I was able to gather the information I needed and have her sign the necessary releases so I could reach out to the rest of her medical team and ensure that we were coordinating and collaborating with regards to her treatment. I applied the information Lily provided against a biopsychosocial framework to help me organize and identify various protective and risk factors associated with her case. I found that most of the biological factors were weighing against her. All of her numbers are shown in ranges recommended for someone fighting type 2 diabetes. With regard to her psychological symptoms, it seems that Lily's path is similar to a lot of women who experience comorbid depression and diabetes type 2. In fact, some researchers claim that depression and diabetes type 2 create a bidirectional relationship. They play off each other. They cause energy problems, sleep problems, digestive problems, lack of motivation, which can all impact self-motivation and self-management, which makes depression worse, which makes diabetes worse. It just goes on and on. Anxiety and substance abuse tend to play along the same lines, so it isn't unusual that Lily is displaying some of these symptoms as well. The social factors in Lily's life are really driving a lot of this behavior as well. The recent divorce and the distance of her children are adding stress and problems, not to mention the fact that they may be indicators that there have been signs and symptoms of dysfunction long before the diagnosis. Sort of makes sense when we think about the fact that Rome wasn't built in a day, right? Work is another social factor that influences Lily. As a prep cook, she's used to working non-typical hours with interference in her feelings of time scarcity, too much sedentary activity, a tendency towards substance abuse, and increased obesity, not to mention a lack of exercise. Her lack of education limits her options in this area as well. Housing is another social determinant that's causing a problem for Lily. She used to share the rent with her husband, but now he isn't in the picture and she's laid off. She's almost out of savings and worried about how she's going to keep her apartment. Research shows that when housing becomes a concern for people with diabetes type 2, there's a laundry list of problems that comes along with it. Clients need places to secure their medications. They need to be able to prepare healthy meals and have money for medication, testing equipment, healthy food, exercise, and medical care. The last social factor I examine in Lily's case is culture and religion. She identifies as 100% Cuban and is a lapsed Roman Catholic. Research has shown that the nuclear family, loyalty, and unity are core values in this population. The sudden loss of so many pillars of social support has to be incredibly tough on Lily to bear. This is just so much added stress in Lily's life as she's trying to learn to manage this new chronic condition. The treatment plan that Lily and I were able to create combined many of these factors with a variety of short-term and long-term goals. First, we focused on the biological goals. We're going to spend the next 6 months working with Lily to develop some new routines with her behaviors. We're going to teach her to test her blood sugar and track it in a journal that can be checked by her community health care worker weekly. We're going to encourage and empower her to go to her doctor's appointments and tests as scheduled. And we're going to help her to learn how to comply with the other recommendations from the doctors. It will all be measured in her health journal, a notebook we've provided for her. Next, we focus on the psychological goals. The set of objectives relate to different evidence-based practices that target specific problems Lily faces. We have CBT that helps the destructive thought patterns and low self-esteem, problem-solving therapy to help her work through the social stressors and triggers and help her to use self-management skills more effectively for her diabetes, and involving her with a support group that gives her more folks she can relate to and reach out to about the problems she's experiencing. Each will be tracked and measured in the thought journal that is a part of the health journal we just talked about. As for social goals, we're trying to help Lily move past the sense of loss she has for the supports she used to rely on and help her develop healthy new supports. She will be paired with a community health worker who shares a common cultural background that can help her on many levels, such as educational and vocational assessment. See if there's other options out there that would help Lily care for herself. Government resources will help Lily to apply for government assistance programs that are designed to lift that burden. Exercise resources help Lily to find local gyms and exercise outlets that are close by and fit her budget. The worker can help her shop and model the appropriate way to research resources of this nature and how to pursue trustworthy information. and of course medical resources. The community health worker will accompany Lily to appointments with her various specialists and help her to increase her medical literacy and help her to learn assertive and effective communication skills to use with medical professionals. These services will be tracked and measured through the tools used in the care management division of the clinic. With all of these arms start working together, we should have a crazy beast ready to help Lily regain her freedom and independence, ready to manage diabetes with ease. But wait, that's not all. I also had to be the patient. For the other side of the exercise, I pretended to be a 48-year-old woman with PTSD. I found a variety of symptoms and resources through websites that gave me a lot of information about PTSD expression and what symptoms I should be displaying for my partner. I also found some resources with details. I decided I wanted my chronic illness to be topical, so I portrayed Susan Wingding, a fictitious survivor of the 2009 mass shooting in Binghamton, New York. The American Civic Association was conducting citizenship classes when a Vietnamese immigrant came in and killed 13 people. In my fictional story, my husband was a teacher who was shot in the room, and I was a secretary hiding under the desk during the ordeal. I learned 3 hours later that my sweet Harry had been killed. Even though it was a long time ago, I am still overwhelmed with flashbacks and intrusive thoughts. I'm emotionally numb, and I avoid anything involving the shooting. My arousal and reactivity are all messed up, and I'm hypervigilant. I try to portray most of these physically during the interview to make it more real for my partner. Before the interview, I completed copies of the PHQ-9, GAD-7, and CAGE-8 as mentioned above, but I also completed a questionnaire titled Severity of Post-Traumatic Stress Symptoms Adult to help my partner to evaluate the degree of severity the interference I'm experiencing from my PTSD is exposing. Altogether, I thought this was a great process to help us understand the depth of information needed to complete a full psychosocial assessment. It helps us to feel the global impact our clients feel from exposure to and experience with these chronic illnesses, as well as the expertise and focus needed by clinicians to adequately and appropriately report diagnoses and decisions. It was an effective and engaging process that's taught me a lot.